Assalamu alaikum, everyone. My name is Khalid Jamiel. I'm a second-year medical student. Thank you all for joining. Today, I'll be teaching biliary secretion and enterohepatic circulation. This is one of the higher yield topics. So inshallah, it's going to be beneficial. So in this lecture, we're going to be talking about biosynthesis and secretion. Then we'll talk about how bile is transported in the hepatobiliary system. And then we're going to talk about the enterohepatic circulation. And finally, the only clinical side of this lecture is gallstones or biosynthesis. So first, let's start with a brief introduction. So the basis of this lecture is going to be following. Bile is synthesized in the liver, and then it's stored in the gallbladder, and then from the gallbladder, it's transported into the small intestine. Okay, so we're going to talk about how it's synthesized in the liver, and then what happens when it's stored in the gallbladder, and then the whole transport system from the liver to the duodenum, and from duodenum back to the liver. Okay, so now why do we need bile? Bile has two main functions. One is emulsification of fat, and two is solubilization of fat hydrolysis products. So what does that mean? So what's emulsification? So this is a fat molecule, right? Something you just ate, and it's broken down in the stomach by pepsin. And then these small fat molecules form. Okay, once this fat is broken down, these small molecules are formed. Now, if these molecules were left alone because they're hydrophobic, they would join back again. Okay, so when they go to the duodenum, they would join back again and form this again. Okay, so you don't want that to happen. So what do? The bile acids, the bile salts, they surround these fat molecules, and they don't allow them to join back to form this big fat molecule. Okay, and what's the point of having or isolating these small fat molecules? It's because the lipases from the pancreas, they cannot break down this huge fat molecule. Okay, they need smaller fat molecules to break them down or hydrolyze them. So that's why emulsification is a very important process. And then once these fat molecules are broken down into either smaller droplets, fat droplets, the bile salts again surround these fat droplets, forming structures we call micelles. Okay, and these help in solubilizing the fat, therefore making it easier to absorb. Okay, it helps in, first of all, stopping the fat molecules from joining back together, therefore helping in the digestion of these fat molecules by lipases from the pancreas. And then once it's hydrolyzed, they form micelles around the fat droplets to make it easier to absorb them, because these micelles can be absorbed by passive diffusion. Okay, all clear until now? So I'll ask you a question. If now that you know the function of bile, if bile cannot reach the duodenum for any reason, whether it was problem in synthesis or transfer to the duodenum, what will happen? Lipids won't be digested. Exactly. Okay, and that's a condition we call steatorrhea, where we have a lot of fat and lipids in the stool. Okay. Now let's revise some anatomy. First, you have the left and right hepatic ducts or bile ducts, and then they join to form the common hepatic duct. Okay. Now this common hepatic duct joins with the cholecystic duct or cystic duct from here to form the common bile duct. Okay, and then the pancreatic duct joins the common bile duct to form the hepatopancreatic ampulla, which opens at the posterior wall of the first part of the duodenum. So this is going to be the pathway of bile. It's going to be secreted, synthesized from the liver, and then it's going to go through the common hepatic duct. Once when the sphincter of Oddi over here is closed, it's going to go back to the gallbladder and be stored in the gallbladder. But if the sphincter is open, then it will continue through the common bile duct, then and then the hepatopancreatic duct into the duodenum. Okay. Now let's revise some histology as well. Once the over here in the liver, once the the small bile is synthesized, it's modified by something we call cholangiocytes. Now, these cholangiocytes are basically the epithelium or the cells lining the bile caniculi. These are small ductules which join together to form the interlobular bile ductules. And then these interlobular bile ductules fuse together to form the left and right bile ducts. Okay, so these small bile canaliculi are what's surrounded by some we call cholangiocytes, and these cells are very important to modify the bile that's secreted inside these caniculi. Okay, and we'll see how bile is modified in a bit. Okay, so that was a brief introduction. Now let's get into the synthesis of bile. So in your lecture, you have a very complicated diagram, which has a lot of molecules that you don't know. Synthesis of bile is very simple. Cholesterol over here is turned into some two molecules. One we call cholic acid, the other we call chenodeoxycholic acid. Okay, and this step is called hydroxylation. Okay, simply we're adding hydroxyl groups. That's where the name comes from. And we're also adding carboxyl groups. And this increases the solubility of cholesterol because we know that cholesterol is non-soluble and we need it to be soluble. We need the bile salts to be soluble in order for them to be able to do the functions that we mentioned at the beginning of the lecture. Do we need to know the name of the products? Just be familiar with them. Cholic acid and chenodeoxycholic acid. This one you don't need to memorize. It just has cholic acid in it. It's one of the bile acids. Okay. Now you need to know this enzyme called 7-alpha hydroxylase. Obviously, this happens in a series of steps. Not all of them get added once, and not all of them get added by this enzyme. But the only enzyme you need to know is this one because it's the rate limiting, and it will be of importance later on in the lecture. So that's it for this step, hydroxylation. And the importance of this step is to increase the solubility of cholesterol, okay? Because the whole point of bile is it being soluble, okay? Now, if you want it to be even more soluble, we do something called conjugation, in which we add an amino acid to these products, the cholic acid and the chenodeoxycholic acid. Okay, and the two amino acids we add are glycine and taurine. Okay, and what does this do? It increases the solubility even more because, as you know, the amino acids have the amine groups and the carboxyl groups, which are soluble, which are polar, and that increases the solubility of the cholesterol even more. And then it also increases the acidity and ionization of the bile acids. Okay, and that's again for the same reason because they have the amine functional group and the carboxyl functional group, which will increase the solubility, and it will open basically an ion group where salt and potassium sodium and potassium can bind, forming bile salts. So until this step, they're just bile acids. Okay, they're acids, and once we add a cation to acids, they form salts. Okay, so we add either sodium or potassium to make them bile salts. Okay, and these two amino acids are taurine and glycine. So what's important from this slide? Just know the steps. First, we have hydroxylation by 7-alpha hydroxylase, forming cholic acid and chenodeoxycholic acid, and then the step called conjugation is where we add taurine and glycine to increase the solubility even more and increase the acidity and ionization. Okay, therefore we can form bile salts. Okay, that's it for synthesis of bile. I guess it's simple enough. Now, bile, the composition of bile. So these are bile salts. Okay, they're not bile. They're not what we call bile because bile is the fluid. So what is bile? Bile is basically bile salts plus cholesterol plus lecithin, which is a phospholipid, plus ions, and also obviously water. Okay, so these are the composition of the bile fluid or bile liquid, and 80% of the organic things. So ions are not organic, obviously, but 80% of the organic molecules are bile salts. So it's mainly composed of bile salts with some cholesterol and lecithin, which are phospholipids. Uh, these are also important in micelle formation, and we'll come to know how later in the lecture. And then we also have ions in bile, okay, and also obviously we have water. Now, an important thing to note is that the ion concentration of bile is isotonic to plasma, okay? So it's not hypo or hypertonic, it's isotonic to plasma. And that means that it will not cause any water movement outside or inside of the bile duct or the common hepatic duct or whatever, so, because since it's isotonic to plasma, bile will not have an osmotic effect. It will not cause water to leave or yeah. So how does bile, once it's secreted in the hepatocyte? So this side is the hepatocyte, okay, and we want to secrete this bile into the canaliculi, okay. So how do we do that? Basically, bile acids, the first component of bile salts, is transported by something we call the bile salt exporting protein over here, okay? So bile acids just enter by active transport. It needs ATP to enter into the canaliculi. And then the other things just enter passively. Cholesterol enters passively, and then phospholipids, which is, or another name for it is lecithin, it enters passively as well. And ions follow the osmotic gradient, okay? And here, over here, this is a function we'll talk about in a bit. It's where cholangiocytes add HCO3 minus bicarbonate, and we'll come to know why also in a bit. But simply this is how these things are transported in, and water obviously just follows the gradient. By the time it leaves over here, by the time it leaves this canaliculi, it's isotonic to plasma. Okay, so there's no more movement of water in or outside. So as we said, transport of bile salt in ductules. Bile salt is by active transport through bile salt export protein. Lecithin is by passive transport. Cholesterol is by passive transport. HCO3 enters and is exchanged with Cl-. We'll talk about this more in a bit. Just note for now that HCO3 entry or bicarbonate entry is the main modification of cholangiocytes. Remember in this slide, we said these cholangiocytes, they modify the bile. So the main modification of bile is secretion or entry of bicarbonate, okay? And bicarbonate is higher in bile than plasma, obviously, because it's actively transported into the bile. So that's why it's higher in the bile than the plasma. That doesn't mean, though, that bile is not isotonic. If one ion is more in the bile than the plasma, that doesn't mean the bile became hyper or hypotonic. There's a balance with the other ions. It just means that the bicarbonate is more in the bile than in the plasma. So you can say it's more alkaline, but you can't say it's iso or hyper or hypotonic. Is that point clear until now? One thing I forgot to mention, these bile acids are called primary bile acids. Okay, why they're called primary? Because these are the first bile acids that are produced. And if there's a primary, there's a secondary. And these secondary bile acids, we'll talk about them at the end of the lecture, and we'll link these information together. Okay, but for now, just know that these bile acids that are synthesized in the liver, they're called primary bile acids. All clear until now? Does anyone have any questions? Okay. So so now we spoke about the synthesis of bile and then the secretion of bile into the canaliculi. So let's treat this like a story. Okay, first we synthesize and then we put them into the canaliculi, and then what happens? We said modification by cholangiocytes. Okay, and then again you see the main modification of cholangiocyte on bile salt is the entry of HCO3. So this is the main thing over here. Okay, now how does this happen? Secretin and VIP activate the CAM pathway. Now you need to start linking information from this lecture with pancreatic secretion lecture, with gastric secretion lecture, any lecture that has secretion in it. You need to link these pieces of information because it makes it easy to get the big picture. Whenever secretin or VIP acts on a cell, it activates the CAM pathway, and secretin usually activates the hydrogen carbonate ions and secretes hydrogen carbonate to make the whatever is in the lumen more alkaline. Okay, so it's a protective mechanism for the stomach. It's a protective mechanism in the duodenum, where secretin acts on hydrogen carbonate ions, or actually CFTR, and then indirectly on hydrogen carbonate ions to secrete hydrogen carbonate to withstand acidity. Okay, so again, it does the same function over here. It increases CAM, and then CAM increases the CFTR in the luminal membrane, and then Cl minus charges this channel. It charges it, and then Cl minus is exchanged with carbonate. Bicarbonate is secreted into the bile. Okay, this is the most important step of all of this. Okay, now there are extra things happening in the background. Where does the supply of the Cl minus? If Cl minus keeps on leaving from the CFTR, then and then coming back, but some of it obviously will stay outside. We need a constant supply of Cl minus, and this comes from the interstitium, from the basolateral. Okay, so this Cl minus charges this, and this charges this. Okay, sodium also enters, potassium also enters. Okay, but this is not important. It's not as important as these two steps. Okay, and then the fourth step over here is HCO3 minus, the one that gets secreted over here. Where does it come from? It needs to come from somewhere, so it comes from the interstitium again through the sodium carbonate or bicarbonate co-transporter, and then finally water follows through aquapores down osmotic gradient. Now this is also important. So you see these underlined bold. If you come out of the slide only knowing this stuff, that's very good. Okay, so secretin and BIP activate CAMP, which activates CFTR. CFTR charges the Cl minus hydrogen carbonate antiporter. Bicarbonate is secreted. Okay, so therefore the bile is more alkaline. And then this channel is what supplies HCO3 from the interstitium to the cholangiocyte. And then finally, water follows through or down osmotic gradient. So how can they ask about this slide in the exam? They'll tell you how is hydrogen carbonate secreted into and then the options will have co-transported sodium. Okay, that's wrong because this is in the basolateral membrane. They're asking about the luminal membrane. They'll ask HCO3 minus Na plus K plus co-transported. That's also wrong. See how they can ask you in the exam. So just know the channels well and know the differences between the luminal and the basolateral membrane. The only things happening at the luminal membrane are the CFTR channel, the Cl minus HCO3 antiporter, and the aquapore. Okay, anything else is in the basolateral membrane. All clear until now? Okay. So the summary of all of this, the modification of bile in hepatic ductules is: one, bile is diluted due to water entry. So water enters, so bile salts or bile acids are going to be more dilute. The second difference is bile is alkaline, okay, which means it becomes less acidic due to bicarbonate entry. Okay, this is a very high yield concept, and you'll come to know why in a bit. But all clear until now? Okay. So let's talk about the transport and storage of bile. Okay. What's this? I can't. Sorry, guys. You'll have to look with the low battery. Storage of bile between meals. Okay. So between meals, we don't want bile to go into the duodenum. So you don't want bile to go into the duodenum. So what do? You close the sphincter of Oddi over here, which is the path of the bile into the duodenum. So if this is closed, it's too much pressure over here. And it's also a lot of pressure over here because the bile is constantly synthesized and secreted in the liver. But this pressure is more than this pressure. And the path of least pressure is where? The gallbladder. It's not contracting. There's no pressure at all. So always fluid. It loves to follow the path of least resistance. Okay? Even in blood, even in vein. Okay? So the path of least resistance over here is going back to the gallbladder. So it comes over here, oops, too much pressure, it comes back to the gallbladder. Okay, and then what happens in the gallbladder? So bile backs up to the gallbladder due to the high pressure caused by the closure of sphincter of Oddi. And this is only between meals because you don't want bile in the duodenum when there's no meal. What do you want to digest exactly? Okay. So what happens in the gallbladder? Two things happen. The first thing, the sodium hydrogen pumps sodium hydrogen exchanger over here secretes hydrogen and absorbs sodium. Okay, and then the Cl minus HCO3 antiporter over here, the same channel we had in the cholangiocytes, secretes HCO3 again and absorbs Cl minus. Okay, and these two are reabsorbed. So the first thing that happens is reabsorption of sodium and chloride, and these two work equimolarly. So they absorb the exact same amount of sodium and chloride. So we can say they absorb sodium chloride because they're the exact same amount. Okay. And then what happens to these hydrogen ions and carbonate ions that were excreted or secreted? They'll join to form water and carbon dioxide, and the water will be reabsorbed. Okay. So we have two things happen: reabsorption of sodium chloride and reabsorption of water. Okay. And the third thing that happens, because this channel works faster than this channel, okay, more hydrogen is being secreted than HCO3, okay? So let's say that 10 hydrogens are being secreted and 5 bicarbonates are being secreted. 5 of the hydrogens will join, or the 5 of bicarbonate, and will form water. The rest of the hydrogens will stay there in the lumen, and therefore this will lead to bile becoming acidic or alkaline. What do you guys think? The bile will be acidic, because more hydrogen is being secreted than bicarbonate. Okay. So do you see that why this is important now? Modification of bile in gallbladder. Bile is concentrated due to water reabsorption. That's the opposite to what we said here. Bile is diluted due to water entry. Now we're reabsorbing water, so bile is concentrated. And the second difference is the bile is acidified instead of becoming more alkaline. It's becoming acidified due to H plus entry. Okay, so let's see this graph over here. As time passes, the bile salt, so the bile salt volume and concentration becomes higher and higher and higher in the gallbladder. Okay, because water is being constantly reabsorbed, sodium chloride is being constantly reabsorbed, and this absorption of sodium chloride will lead to reabsorption of more water following the osmotic gradient and so on. Okay, so as time goes for the bile in the gallbladder becomes, the gallbladder has more and more concentrated bile. Okay, that's the first difference. And if you look over here, the bile salts in the gallbladder, or the bile salt concentration in the gallbladder, is much, much more than the bile salt concentration in the liver. Okay, and now we know why. So this is a high yield concept. They're probably going to ask you about the differences between the bile in the gallbladder and the bile in the liver. Okay, and then we'll also see that sodium is more in the liver bile than the gallbladder bile. That's also because sodium is being reabsorbed. Chloride as well is much lower in the gallbladder than it is in the liver bile, because chloride is being reabsorbed in two places. In the liver, it's being reabsorbed, and also in the gallbladder is being reabsorbed. Okay. And finally, HCO3 is lower in the gallbladder than in the liver bile. Okay. So everything makes sense over here. And then finally, pH. We said that gallbladder is going to be more acidic than liver bile because H plus is being secreted. Okay, I think this is a simple concept, but still keep in mind that bile everywhere is isotonic, whether it was in the gallbladder, whether it was in the liver, whether it was in the ducts, it's always isotonic to plasma. Micelles or bile do not have an osmotic effect. They don't pull water, they don't push water. They're just there, okay? Because the ion concentration is isotonic to plasma. Don't look at the numbers and say, how is it still isotonic? The numbers change. Yes, exactly. All the numbers change, and there's a balance of tonicity between bile and the plasma, blood plasma. Okay. Now let's talk about the contraction of gallbladder and opening of sphincter of Oddi. We spoke about when we're in the interdigestive phase between meals. Now, what happens if we eat and we want the bile to go out? The gallbladder will contract and the sphincter of Oddi will open. Okay, so you're causing pressure in the gallbladder, then you're also releasing the pressure from the sphincter of Oddi, and then now that's the path of the least resistance going to the duodenum. Okay, so now how do these things happen? Gallbladder contraction and sphincter of Oddi open. We have a very important molecule called cholecystokinin. Now, secretin is for rest phase. It's always secreted in the resting phase because it's secreting hydrogen carbonate to neutralize the acid everywhere in the GI. Okay. However, cholecystokinin is always secreted when we eat. Okay. This is important to link the concepts together with the gastric secretion and small intestinal secretion. CCK secreted when we eat. Okay. Now from the name, cholecystokinin. Cholecyst is the gallbladder. Kinin means movement. Okay. So it moves the gallbladder. It causes the contraction of the gallbladder and the releasing of bile into the duodenum. Now, how does it do that? There are two pathways. Okay. So cholecystokinin is released by eye cells in the intestine. Okay, when it detects fat or when food enters the duodenum and it detects fat, protein, but mostly fat. Fat is the most potent bile. It's the most potent bile acid stimulator. So the CCK it has two pathways. One of them is a minor pathway in which CCK acts directly on the gallbladder. Okay, it goes to the gallbladder, acts as a hormone, and directly causes the contraction of gallbladder, and that's it. But this is a minor pathway because we need two things. We don't need one thing. We need two things. We need the contraction of the gallbladder, and we need the relaxation of the sphincter of Oddi. And so the other pathway does these. So what happens is when cholecystokinin is released, it uh, binds with the vagal afferents. Okay, afferent means going to the central nervous system with an A. Afferent means goes to the central nervous system, and then efferent with an E means going out uh, of the central nervous system. And this efferents, they're always carrying the action. Okay, so if it was a motor action, it will carry the motor fibers. If it was a parasympathetic action like this, it will carry the fibers of the parasympathetic to cause the effect. Okay, so basically what happens, cholecystokinin binds with the vagal efferents. Afferents, they go to the vagus nuclei in the brain, and then the vagal nuclei activate the vagal efferents, which cause the effect, two effects. One, it releases acetylcholine in the gallbladder. Acetylcholine is always excitatory. It excites the gallbladder, causing contraction. And then it also releases nitrogen oxide and VIP, which again link all the lectures together. Whenever you see nitrogen oxide, it always causes relaxation. And this comes in the motility lecture, I think. It always causes relaxation. So it relaxes the smooth muscle and the sphincter of Oddi, causing gallbladder to move right into the duodenum. Okay, all clear until now? Okay. So now, once the bile has two functions in the duodenum, emulsification and solubilization of fat hydrolysis products. So let's see how the micelles form. So basically, bile salts are amphipathic, okay? And amphipathic, like you took in mol 1. Can you guys hear me or is my voice cutting off? So as we said, we already spoke about the action of bile in the duodenum, which was emulsification and fat and solubilization of fat hydrolysis products. So we'll just talk about it again. How do micelles form? Bile salts are amphipathic. Okay, so they have a hydrophilic group and an hydrophobic end. Okay, and so the hydrophilic ends, they surround the hydrophobic ends like this, forming a circle, which we call micelle. And sometimes cholesterol we find inside these micelles, and now we call them mixed micelles. Okay, these micelles, they also form in the small, they're in the bile normally, and they also form in the small intestine with the duodenum around fat acids, around fatty acid droplets. Okay, and as we said, it has very little osmotic activity because the ion surrounding it is isotonic to plasma, and they themselves, they don't cause water movement outside the inside. They have low osmotic activity. Okay, so bile salts and phospholipids are amphipatic. Therefore, they can form micelles. Once they're mixed with cholesterol, they're called mixed micelles. This is not very important. If the function in solubilizing fatty acids and making it easier to absorb, this is what's important. Okay, and emulsification as well is important. Okay, so any questions until now? Okay, we can move on. So, enterohepatic circulation. Now, from the name, enterohepatic circulation. And yes, can you please recap that part? Okay, 1 second. So, I was just saying that the bile, once it enters the duodenum, okay, they form micelles. The micelles that we spoke about at the beginning of the lecture. Let me just go back quickly. Over here. Okay, we said that one of the functions of bile acids is solubilization, in which the bile acids, they form a circle around the fatty acid droplets that were just hydrolyzed over here, making it easier to absorb by the enterocytes. Okay, so this is its importance. It makes it easier to absorb fat. Okay, now how do these micelles form? We said the bile acids and phospholipids are amphipatic. Okay, so they have polar groups, hydrophilic groups, and they have non-polar groups, which are hydrophobic groups. Okay, so the hydrophilic groups, they love water, they love liquid. Okay, so they stay on the outside, and they hide inside the hydrophobic non-polar groups. Okay, forming a circle like this. You can think of it like a submarine. Okay, and inside we'll have cholesterol, we'll have phospholipids, and then we'll have also the lipid fatty acid products that were produced in the duodenum. Okay, and then this whole micelle just enters passively into the enterocytes, into the duodenum, because it's a lipophilic membrane, so they can enter easily. Okay, and that's how they make it easy to absorb fatty acids. Okay, because fatty acids cannot just cross; they need the micelles. Okay, which makes it easier to absorb large amounts of fatty acids and easily. Okay, this is very important in absorbing lipids. Clear now? Okay. Now we spoke about what bile does in the duodenum. Then what happens after the bile does its job in the duodenum? We need to either take it back or secrete it. So the fact is, bile, only 5% of the bile is newly synthesized. 90% of the bile, or 95% of the bile, is reabsorbed from the large intestine or the ileum and the colon into the liver again. Okay, so we don't need to synthesize a lot of bile salts. We only synthesize 5% a day of the bile salts we have. 95% is being reabsorbed from the ileum and the colon. Okay, so and this is what we call the enterohepatic circulation. Are the cells in the small intestine, enterocytes, hepatic, the liver, and circulation. Okay, so it's a circulation. Now, in the enterohepatic circulation, as we said, 90% of the bile is absorbed from the ileum. Okay, 5% of the bile is reabsorbed from the colon, and 5% is excreted, and therefore we synthesize 5%. Okay, because we need to bring back this 5% that was excreted. Now imagine if someone had to take out the ileum for any reason. If they had Crohn's disease, for example, they need to take out the ileum. So ileal resection. Now, the bile will no longer be reabsorbed, okay, and therefore you will not have bile to secrete, and therefore you have steatorrhea, okay. So try to link these basic concepts with the clinical concepts, okay. Ileum is very important in reabsorbing bile. If we don't have an ileum, we won't have reabsorption of bile, and the liver simply uh, can't compensate for this huge loss. 90% of its bile is being lost, and therefore we'll have fatty acids. We'll have abdominal pain and many other problems. Okay, fat needs to be reabsorbed before it gets to the colon, and or else it will cause problems. Okay, so this is basically the enterohepatic circulation. Now, how does it get reabsorbed over here? طبعا it gets reabsorbed through the blood. It goes through the portal circulation. It goes to the liver, through the blood outflow. So from the ileum and the colon, it gets reabsorbed to the blood. Well, how does that happen? We're in the ileum right now. Okay, we have bile acids. Okay, or probably bile salts by this stage. We have taurine and glycine, so they're conjugated bile salts, primary bile salts. These are what we call primary bile salts. Okay, and lining the ileum and the colon, we have bacteria. Okay, the normal microflora, and they just live there normally. The bacteria of the gut. Okay. Now, what do these bacteria do? They feed on these fatty acids, okay, by a process we call fermentation. Fermentation, what does it to the bile acids? It deconjugates them again and dehydroxylates them. So basically reverses the process of synthesis of bile acid, okay? And once it does that, the deconjugated bile acids are just absorbed passively. They can just pass into the blood outward through the membrane, to the membrane of the ileum, okay? But the conjugated bile acids, since they're polar, okay, some of them don't get deconjugated. Not all of them get deconjugated, but majority do. However, the remaining that don't, you also need to reabsorb them. So we have a special channel for them in the distal ileum. The reason I drew it here is because it's in the distal ileum, the further part of the ileum. We call it ASBT. Okay, so this channel, it actively reabsorbs the conjugated bile acids. Okay, and all of this goes to the blood, and then from the blood goes to the liver, and we'll see what happens in the liver later on. Is this point clear? So bacteria ferment the conjugated bile acids, forming deconjugated bile acids. These deconjugated bile acids can simply be reabsorbed passively into the blood. Whatever is remaining from the conjugated bile acid will be actively reabsorbed by a channel called ASBT. Actively means it needs ATP, it needs energy. Okay, and then the blood will take it back to the liver, the portal system. Clear until now? Yes. Now we're back to the liver. What happens? You remember this diagram? I just hit this part of the diagram before. What happens when these bile salts come back to the liver? Okay, it's called the circulation. So it needs to come back to the liver, and then from the liver back again to the ileum. So we have two channels here. Okay, one is called organic anion transporting protein. This, it reabsorbs the deconjugated bile acids, okay, or unconjugated bile acids. It gets reabsorbed through OATP channels, okay, and the conjugated bile acid enters through a channel we call NTCP. You don't need to remember these big names: sodium taurocolate, co-transporting peptide. They'll always give you the what's it called, abbreviation. Okay, so OATP and NTCP. OATP is for deconjugated, NTCP is for conjugated. These channels are very important. Okay, they're highly. And once the unconjugated enters, it will get conjugated again through addition of through first of all hydroxylation by 7-alpha hydroxylase, and then addition of taurine and glycine. Okay, and then these will enter the canaliculi by BSEP. Again, this transporter again, which is called bile salt export protein. Okay, and this is an active process that needs ATP. It's also important to know which channels use ATP and which don't, because I can see it being asked in the exam. So the only channels that need ATP or active transport are ASEP, bile salt export protein, and this one over here, ASBT. Okay, this one also needs ATP. Okay, and then from here it will everything we spoke about will happen again. We go to the ileum, it will come back, and then it should happen. Okay. So now how do we regulate biosynthesis and biosecretion? Okay, and then we come back to a very important concept again, 7-alpha hydroxylase. You remember we said this is the rate limiting step in biosynthesis. So rate limiting just means that this is the enzyme that's getting control to upregulate and downregulate the process. Okay, so if we have high portal blood bile circulation, what does that mean? We have a lot of blood coming back from the ileum. Okay, we have a lot of blood coming back from the ileum. Do we want to secrete more bile? I mean, do we want to synthesize more bile? We don't want to synthesize more bile because we're already getting so much back. Okay, so we'll just secrete whatever we have and get it back again from the ileum. Okay, so if we have high portal blood bile circulation, so the bile in the portal system is high because a lot is getting reabsorbed, we will inhibit biosynthesis. We don't need to make any more bile. There's already so much bile in circulation. We don't need more bile. So we'll inhibit 7-alpha hydroxylase and then upregulate the BSEP, this channel. So more bile will be secreted. Okay, it makes sense. There's no need to memorize anything in this lecture. Just need to understand the flow and the story of how bile circulates and what happens at which step. Okay, and then if we have low portal blood bile circulation, that means we simply don't have enough bile. Okay, or the liver thinks that we don't have enough bile, so it stimulates 7-alpha hydroxylase and it downregulates secretion. Okay, you want to make as much as you can and you don't want to get rid of it, so you stimulate 7-alpha hydroxylase, which is the synthesis of bile, and then downregulate BSEP, which is bile secretion. This is a very important concept. Is this concept clear for anyone, for everyone? Okay, so now let's talk about bile acid regulation in different phases. We have 4 main phases. We have the cephalic phase. The cephalic phase tells you that you're about to eat, right? So taste and smell, they stimulate the vagus afferent, which stimulate then a vagus nucleus, which then stimulate the vagal efferents, and then the vagal efferents does the same actions as we said. It releases acetylcholine at the level of it releases acetylcholine in the cholecyst, okay, and it also releases nitrogen oxide to relax the sphincter of Oddi, okay, and therefore increases the gallbladder emptying, okay, because food is about to come. You don't need to memorize this, you can also understand, okay? Then the gastric phase, food already came in the stomach. So the duodenum needs to prepare itself for the food incoming. So the gastric distension stimulates the vagus and therefore increasing gallbladder emptying again through the same process, okay? And finally, intestinal phase, fat digestion product, they stimulate CCK release, we already spoke about this, and therefore stimulating vagus and therefore stimulating gallbladder emptying. So all of these things means that food came, okay? Cephalic phase, gastric phase, and intestinal phase. What about the interdigestive phase between meals? You don't need bile in the duodenum. There's nothing stimulating you to release bile, so the sphincter of Oddi should be closed, صح? Remain closed. So the low rate of bile secretion in the duodenum will tell the vagus and the gallbladder that I don't need to secrete any more bile. So low bile in the portal, low bile in the portal blood, and therefore inhibition of bile secretion, as we said over here. Okay, all clear until now? Right now, we'll talk about the final concept and the highest yield concept of this lecture, gallstones. Okay, so what is a gallstone? Gallstone is basically when cholesterol crystallizes in bile. Okay, it forms crystals, and these crystals of cholesterol is what we call a gallstone. Okay, and this forms due to imbalance in cholesterol and bile acid concentration. So usually cholesterol should be solubilized inside the micelle, inside the mixed micelle. Do you remember? Inside the mixed micelle, over here, cholesterol is solubilized. Okay, if we have too much cholesterol, uh, it will crystallize. It will start to become, because it's hydrophobic. Okay, so it will join together and crystallize, forming gallstones, which we don't want, obviously. So therefore, we want cholesterol always to be solubilized inside micelles. Okay, but many things that happen can lead to crystallization of cholesterol. So there are three main things. First of all, extra cholesterol levels. Someone with hyperlipidemia, someone with high cholesterol levels, basically, old people, they have high cholesterol. And so that is a risk factor of forming gallstone. Okay, we have high cholesterol levels. Another reason is low bile acid concentration. If you have normal levels of cholesterol, but nothing to solubilize it, then we're at risk of forming gallstones. Okay, and finally, low phospholipid concentration, because also a lot of phospholipids help in forming the mixed micelle and solubilizing cholesterol. So that's why if you have low phospholipid concentration, also a risk of forming gallstones. Now, this is just an extra piece of information. I very much doubt they'll ask you about this, but some micelles have many layers, and some micelles have one layer of bile salts and phospholipids. Okay, so the many layers cholesterol we call multilaminar. Okay, and that just means it has like many layers above each other of phospholipids and bile acids. Okay, covering the cholesterol. Now these are unstable, and therefore, if we have higher level of uh, micelles, will be a higher risk of crystallization or gallstones. But this is not important, honestly. I just put it for the case of for the sake of completion. There's also the triangle that's in your slides. That's also not important. All that's important from this concept is that gallstone can form due to extra cholesterol levels, low bile acid concentration, or low phospholipid concentration. Okay, and these are the steps it follows. This is also not that important. So supersaturation, so saturation of cholesterol because of one of these three reasons, and then they form small crystals here and there, nucleation, and then they form a microstone, which will eventually turn into gallstone if more crystals join. Okay, so now this is a very important concept. Gallstones can happen in different parts of the hepatobiliary system. Okay, and depending on that part, you'll see different symptoms. Okay, so let's test anyone who's here. Wait a second. Okay, so we can have bile or gallstones in different places. One of them is in the cystic duct. Okay, and one of them is in the common bile duct, and the other one is around here in the sphincter of Oddi or in the ampulla. Okay, so these are the three most common places where gallstones get stuck or any cause obstruction. Okay, and obviously obstruction will lead to many problems, and depending on where it gets stuck, will have different symptoms. Now, if the gallstone gets stuck in the cystic duct, what do you think we'll see? What are the symptoms, or what are some of the symptoms we will see? Okay, someone said pain due to what? Obstructed bile secretion. Okay, so someone said jaundice, nausea. Okay. So there are three things we need to focus on. Okay. Where will bile accumulate if steatorrhea? Okay, that's a good guess. Okay, that's a good guess. Where will bile accumulate if there's an obstruction in this area? That's one thing we need to think about. And then what will happen to the bile? Will it be able to reach the duodenum or not? And then also if there's any organs it will back up into. Okay, so if the gallstone happens in the cystic duct, a good guess would be steatorrhea, but unfortunately that's not the case. Most of the bile that goes into the duodenum can go through the from the liver directly. Okay, it doesn't need to come from the gallbladder. In fact, if we remove the gallbladder for some patients, cholecystectomy, there won't be that much effect in digestion. Okay, maybe sometimes you'll see steatorrhea, sometimes you'll see uneasiness in the stomach, but you won't see that much of a difference. Why? Because there's still constant supply of bile into the duodenum from the common bile duct. Okay, there's still a supply. If a blockage happens here, there's still a supply of bile into the duodenum. Okay, from the liver outward. Okay, so the only thing that will happen is that bile will come back and accumulate in the gallstones. Okay, and I mean in the gallbladder. And then what will happen? If bile accumulates over here, you'll have acute cholecystitis, okay? Which means inflammation, as we said, well done, Maya, inflammation of the cholecyst, okay? And that the main symptom of that is pain, okay? Whenever the gallbladder contracts, whenever you eat a fatty meal, the gallbladder will contract because there's gallstones over here causing blockage, and there's inflammation in the cholecyst itself. It will cause a lot of pain. However, it won't cause like significant steatorrhea or jaundice. Okay, because most of the bile osmond is flowing through the common bile duct. One second, let's go back. Now, what happens if there's a blockage in the common bile duct? Let's go again, another round of guessing. Think, will the bile be able to reach the duodenum in any way? Okay, so steatorrhea, that's correct. What else will you be seeing? Jaundice, excellent. What else? Okay, so good guesses. Okay, so steatorrhea is correct because bile is not reaching the duodenum, and so you'll have steatorrhea because there's no emulsification, there's no solubilization. Therefore, you have steatorrhea. Okay. Another thing you'll see is again cholecystitis because again bile will also build up in the gallbladder, causing inflammation and cholecystitis. Okay, and finally jaundice. Now there's a green pigment. One of the constituents of bile is bilirubin. Okay, and this is the main topic of the next lecture. After this, next physiology lecture, it's bilirubin. Okay, bilirubin is the green pigment, is what gives bile its color. Okay, and now if bile is stuck in the common bile duct, okay, this bilirubin will start leaving from the bile and from the liver, causing jaundice. Okay, it will go to the blood and cause jaundice. Okay, and finally, the last place is the last place is the sphincter of Oddi. Okay, now this is the worst one. If bile accumulates in the sphincter of Oddi, I mean, if gallstone happens in the sphincter of Oddi over here, okay, what will happen? What do you guys think? Pancreatitis, excellent. Why pancreatitis? Because now it's not only there's not only a blockage in the common bile duct, and backflow won't only happen to the cholecyst in the liver, it will also happen to the pancreas because this is the hepato-pancreatic duct. Okay, and so whatever enzymes were being secreted into the duodenum won't be able to go there anymore, and it will be stuck in the pancreatic duct. Okay, and usually they're zymogens. Okay, they're not active enzymes. But if it builds up here for a long time, they will become active enzymes and they will break down the wall of the pancreas, causing pancreatitis. Okay, and along with all the other symptoms, you'll have jaundice, you'll have steatorrhea because bile is not reaching the duodenum anyway, and you'll also have cholecystitis. So there's backflow of everything everywhere. Okay, so this is the worst one. This is the best one, and this is easier. So this is the highest yield of this highest yield part of the lecture. And that would be it. Does anyone have any questions? You need to practice on these, know exactly what happens if the gallstone is stuck in each part of this duct. You need to know exactly what happens. Okay, this is very important. Can the bile be reabsorbed through either of the ducts? No, reabsorption of bile only happens in the ileum and the colon. That's the only place where bile is reabsorbed. That's why if you remove the ileum, you won't have reabsorption of bile anymore. Okay, any more questions? So yes, that's it. Please scan the code. Thank you guys so much for attending. And Assalamu alaikum.